I have an alumni of the University of Minnesota School of Public Health and Hopkins Bloomberg School of Public Health, and experienced qualitative and quantitative researcher with interests in maternal, infant, and early childhood health and nutrition, HIV/AIDS prevention programs, and demanding solutions to global health care disparities. He has supervised hundreds of PhD candidates, a peer reviewer for social science and medicine, the Journal of Nutrition Education and Behavior, and the Journal of Agriculture, Food Systems, and Community Development. He serves as a contributing faculty member with the Walden College of Health Sciences and as an adjunct contributing faculty member at 4 other land-grant institutions. It is my privilege to welcome this Fulbright scholar and USP Score volunteer in Tanzania, Dr. Patrick Tschida, to our podcast. Dr. Tschida, it's an honor to welcome you to Morbidity and Mortality Podcast today.
Thank you so much, Dr. Nduka. The honor and privilege is all mine. I'm really happy to be here with you. And I do want to say that the College of Health Sciences at Walden University is now changing its name to the College of Health Professions because the College of Nursing and College of Health Sciences have merged. So they are now officially the College of Health Professions.
That is good to know. And I like the broad perspective they've taken in that direction. Thank you for that information, Dr. Tschida. So Dr. Tschida, today I would like us to just brainstorm around social determinants of health as they relate to the current public health issue that we have globally, which is COVID-19. So we are going to touch on housing, local food markets, education, job opportunities. If time permits, we are going to also touch on access to healthcare services, transportation, public safety, social support, crime and violence, access to technology and so on. So first, Dr. Tschida,
Yes.
could you describe to our audience the beginning or genesis of COVID-19 and how it was transmitted to the US?
Yeah, so the organism is a coronavirus SARS-2 viral infection that existed normally and naturally in animal wild population. So it's a zoonotic disease, meaning it jumped from animal into human populations. And that generally happens when humans and whatever species it is that organism exists in are starting to live closer and closer together. In this case, the organism jumped from what is believed to be animals in the Far East, particularly in China, called pangolins, which are a scaled, I imagine it's somewhat like an aardvark animal that have scales on the outside, and they were in an open market, wet market in a town called Wuhan, China, whereby when these pangolins were being marketed, some of the organisms then became released and were inhaled or somehow, it made their way into the human population and began making humans ill. Never having been to Wuhan, only seen video clips of the open market, these were being done, this trade of this organism, this pangolin animal was being done in a clandestine fashion because they were protected. And the scales, when they're pounded, are apparently an aphrodisiac. So there's still a high demand, but not a legal means to obtain them. So it was being done in a fashion where people were doing it in a secretive manner. And unfortunately, it's novel, meaning it's never been observed in the human population before, and it's not really well understood how we develop immunity against it and how to survive it once we're infected with this organism. And it is has a very high case fatality rate associated with it. There are many people who are saying it's no different than the common cold, and that is simply untrue. We have about at least 100 times higher case fatality rate, if not 1,000 or 10,000 higher case fatality rates associated with this illness than the common cold, which is a rhinovirus. It's also a virus, but it's a different type of a virus. And sadly, this particular virus is disparately impacting people who are elderly, people who already have other underlying comorbidities, and people who otherwise have limited access to healthcare systems where they can get tested really quickly once they start to develop symptoms, and then onto the appropriate kind of respiratory supportive care that they may need based on how they respond, to the illness itself.
Right. So thanks for bringing that broad perspective with regards to COVID-19. You mentioned that it's a zoonotically transmitted virus, and the original thought that it's a common cold is appears to be not factual. So I hope our audience are listening to this and begin to take this virus, more seriously. And having said that, Tone, can you give us your assessment of this pandemic with regard to housing discrimination in America? For example, in America, there's something called the Fair Housing Act. And this Fair Housing Act prohibits housing discrimination based on sex, color, religion, national origin, familial status, or disability, also known as protected classes. But it seems that some people have been evicted and discriminated against based on perceived connection between their race, national origin, and even disability. So what is the assessment of this situation?
Yes. So we unfortunately had people, including people in very high ranking positions in our federal government, refer to this as the China virus or the Chinese virus, which is sad because we here in the Midwest, in particular in the city that I live in right now, have a high percentage of people coming from Southeast Asian countries, some Vietnamese, Hmong, Laotian, Korean, and I was living in an eastern metropolitan suburb prior to moving back into the city myself recently here, but I had a neighbor who had unfortunately had last spring, around about March, April, or May, notes on their front door. They happened to be Southeast Asian immigrant family, young family, man, a woman, and their children, who were given notes on their front door that, should have been investigated as hate crime. Unfortunately, the police dismissed this as just a child prank, but they were given notices on their front door saying, we don't want your kind here, please leave. You bring diseases into our country, which, this was a family that is second generation Southeast Asian immigrant. They had nothing to do with bringing any disease anywhere. In fact, the wife works as a nurse. The husband works as a mechanic. They're contributing members to society and should not be subjected to discrimination in any way, and certainly not have this virus or this pandemic be blamed on them. It's unfortunate that this occurred, but this could have easily occurred in a marketplace anywhere in the world, in the U.S., in Canada, in South America, in Asia, anywhere. And it just so happens to have happened in an Asian country. But this doesn't mean that Asian people have a higher, risk factor of carrying this illness, nor do they have a higher rate of transmission. There's nothing. It's a non-discriminatory virus that's going to infect the entire human population, as we have seen. It spread quickly across the globe. And I think that social scientists and epidemiologists and those that are tracking movement of organisms around the globe have found that this not only came from the West Coast through someone who had recently returned from China, but was probably also coming in another strain of this virus coming in from the East Coast
Yes.
simultaneously. Yeah. So, sadly, there's discrimination going on the basis of one's national origin, religion, race, gender identity, and landlords who want to use this opportunity as a means to say they don't want certain types of people in their buildings will do that, and it's illegal. It's sad that that's happening. I know here in the Midwest we have our state representative Ilhan Omar, who has called for a moratorium against evictions. We're fortunate for her work. Our representative Omar, who we're very proud of, and has done tremendous work for women and children and people who are new immigrant families to the U.S. But in our metropolitan area of Twin Cities, Minneapolis, and St. Paul, the increasing numbers of people experiencing homelessness is unconscionable to me. Homeless encampments are popping up in every public park across the entire Twin Cities of Minneapolis and St. Paul right now, and into the suburbs. Something which I never would have dreamed or guessed I could witness in my own birth city, my hometown, and it's heart-wrenching. Certainly the CARES Act has provided funding for people to, more shelters have opened up, more abandoned hospitals have been converted to providing care for people with COVID and providing shelter for those who are experiencing non-sheltering right now. But it feels like it's only a drop in the bucket compared to the need. There's so much need. And it's a need for not only housing, Dr. Nduka, but also food. And, it's shelter. It's all basic needs. Having access to clean drinking water right now is becoming problematic. Many places where drinking fountains used to be public accessible are closed and shut down, and the water's been turned off. So people are really struggling, not only from the standpoint of having adequate shelter and housing, but having enough food, and clothing and access to water and just basic necessities of staying alive, of survival.
Yeah, I agree with you. There is need almost in every nook and cranny of our system, and it looks like almost all the structures are crumbling, so to say. When you look at the transit system, it is not anything to write home about. So how has this pandemic affected the transit system in America? I was reading a Times Magazine article. It was published on July 21st, and it was titled "COVID-19 has been apocalyptic for public transit." So many transport departments cut down on their routes. Even here, I live in Denver, Colorado. The regional transportation department cut down like almost 90%, at the peak of the pandemic, and that made it tough for people to access healthcare, when especially the poor people, when they can move from one point to another. So what stories have you read about or had, from those who feel that the society has left them behind, especially at this time?
I forgot to unmute myself. I'm sorry.
It's okay. It's okay.
When I think about the impact of transportation systems in times of crisis and how people end up being, left behind, figuratively and literally, I think of our tragic Hurricane Katrina crisis situation where evacuation routes were opened for people to leave the metropolitan area of New Orleans, Louisiana. However, public transportation shut down completely. So if one did not have a personal vehicle or have a relative or family member or friend who was willing to make room in their vehicle, those were many of the individuals who got trapped behind. They were simply trapped in their homes with no means of evacuation. And I know the major news sources were claiming that these were people who chose not to evacuate. I think a very small portion of people chose not to evacuate. And many of those who perished in the flooding that ensued during Katrina and shortly after Katrina were people who simply had no means of transportation out of the flooded area. And in a sense, it's a different kind of entrapment occurring right now. If someone does not have access to public transportation, and I know in our area here in the city I'm living in, people are advised not to take public transportation unless they absolutely have to reach their place of employment or reach a clinic or a hospital or reach a grocery store or drugstore if they needed to pick up necessities for their own survival. But it's happening here as well. Routes are being, cut because of lack of use. And so those that relied on those routes are often then without any means of transportation to get about and do one's, acquiring of basic necessities for continuing to survive. And again, luckily, many response is going into effect at the local, city, state level to provide people by delivering of groceries and medications and food to school children. I know throughout even the summer months, many children in our area depend on their lunch meal to be provided by the school system. And when children weren't going into the classroom any longer, in the spring and summer months, there were school buses, even in the neighborhood where I live here, with the school staff delivering meals for school children to their homes, into their apartment buildings, into the neighborhoods, so that there was still at least one meal a day that people were getting. But yeah, the transportation system has been impacted. I believe every sector of our lives have been impacted. Many businesses here now are boarded up. Some have gone under completely, we'll never see again, and some have just closed temporarily. It's impacted every aspect of our economy and every aspect of our lives.
It has indeed, including the school system. And Dr. Tschida's school resumption has been a big concern. Lately schools have resumed, and some schools resorted to hybrid format of delivering education. Others, went 100% online. In Israel, let me give you that instance with Israel. After they reopened schools, about 1,300 students and 691 staff were affected by the virus. And the Associated Press of May 18, wrote this. They said, I'll read out what the Associated Press said. They said, just 1 week after a third of French school children went back to school in an easing of coronavirus lockdowns, a worrying flare-up of about 70 COVID-19 cases has been linked to schools. So why can't the US learn from the missteps of other countries?
That's an excellent question. I think in the US we have such a different geopolitical history, than France or than Israel. And I think that sometimes to our detriment, we have such a sense of fierce individualism, that America wants to do what it does its own way. And, and I think, some of that individualism and can be a detriment, particularly when it comes to provision of a basic standard of education, a basic level of access to healthcare. And I know at least here in Minnesota, it seems as though we have a very big rural-urban divide where our urban schools are using some sort of either virtual distance learning modality for instruction for students. Most students, at least middle school and high school students, are in a virtual environment, but elementary schools have gone to some hybrid where the children are in classroom at least part of the school week. However, in our rural communities outside of the large metropolitan areas, they're almost 100% in classroom. There's no virtual learning going on. Some of that is lack of access to the internet and being able to provide online learning, and some of it is that in rural areas, people just do not seem to believe that this is that much of an issue as we know it to be, in more densely populated areas, such as in urban settings and in the inner cities. So, it's unfortunate that we've not been able to learn from other countries' examples, but it does seem to be very tailored to each school district. And we have kind of very decentralized school systems here in Minnesota where each township, city, locality, municipality has their own school board that functions as a separate body and entity in tandem with the city's infrastructure, and every school board is handling it differently. It's just very much a piecemeal approach, even though we do have a Democratic governor right now who is a former school teacher and school administrator. It's still very localized and decentralized, and every school district is doing it differently. So it's just very, I believe it's very problematic because it feels very chaotic, and very piecemeal. It's a very piecemeal patchwork quilt type of approach. So there's no way to really standardize and then perhaps even be able to evaluate what might be working in one area and is working better, and that we can apply it in another area, because there's not even a means of saying this is what we implemented and we've evaluated it and please try it because we believe it'll work in your area. I mean, evaluations I believe now have begun. In fact, I'm involved with some evaluation of the CARES COVID response in my county. But we're really now, I think, at the point where we need to really start pivoting to thinking now about how are we going to encourage people to willingly get the vaccination. That will be rolling out very quickly. In some states I'm hearing as early as before the end of this month, there will be hundreds of thousands of doses being administered to healthcare workers and frontline workers and those in long-term care facilities and assisted living facilities. Our Commissioner of Health, Commissioner Jan Malcolm, has talked about, based on profession, one is either in an A1 categorization or an A2 or A3 and then on to the B. And the general population, like yourself and myself, if we're not directly involved with caring for patients, perhaps sometime in the spring or summer of 2021. And I will willingly wait my turn in line and get it, when it is available. But I'm hearing a lot of people being fearful that, I've heard people refer to it as the Bill Gates vaccine, or that it's not going to be something that will matter if you get it or not, or that it's somehow going to be harmful, which I've even heard people in the public health fields, believe it or not, say they don't believe that an effective and safe vaccine could have been developed as quickly as we have had these various pharmaceutical companies develop, Moderna, Pfizer, and AstraZeneca. Namely, I believe that they've used the same strict and stringent protocols for the development of the vaccine as in any other time. The difference being that they were able to fast track the federal authorization processes that normally would have had to have waited years and get in line and just wait your turn. These were now put to the front of the line, and that's why they were enabled to do it as quickly as they were. But I think 30,000 people in each trial, phased in beginning in, I believe, the month of June, 30,000 each month for 6 months. So there's 6 trials that ensued earlier this year. And, certainly there's not a perfect scenario, but these are the best that we have for now, and they will save lives. And I believe that people need to not be falling prey to some of the myths that are spreading around on some conspiracy theory sites about the vaccine going to have the ability to somehow implant a microchip in your brain cells and make you, behave in a certain way. That's science fiction. That's not a reality. And the vaccines that we know, against childhood diseases, the DPT and MMR vaccinations have saved hundreds of millions of lives globally. This will also be able to save lives, and people need to be willing to believe the science and believe that these vaccines will be effective, and not fear them. They'll help. They won't hurt. They'll help.
Yes, these vaccines will help, not hurt, and I'm glad you addressed the falsehood being spread out there, and people believe in those falsehoods, and that's one reason we have this podcast, so that we can educate the public, give them proper public health information, not distorted and kind of like John Diced, point of views, So I'm so glad you addressed that point blank. Thank you, Dr. Tschida.
When I thought of it in the sense of schools, because I know in school, for myself as a preschooler, I obtained the polio vaccination when it was being administered orally in the early 1960s. I'm aging myself here. But it was a small cup of cherry-flavored liquid that we had to go, and the entire family marched down to the elementary school to get our doses of the new polio vaccine that was coming out at that time. And I have cousins on my mother's side who succumbed to the polio pandemic, and one in particular who's in a wheelchair. Thankfully, she survived. But this is another example of how we have to believe in our scientists and believe that the vaccinations, in whatever infrastructures will be used to administer them, if it's a school, if it's a clinic, if it's the for-profit drugstores like CVS's and Walgreens, whatever it is, we need to encourage people to get the vaccine when it's available and ready.
Right. And public health organizations and institutions and schools that have public health departments, they should, begin to, speak out, attend both virtual and, if possible, in-person talk shows, and begin to let the people know that, hey, yes, we know that the trust of the government is not there, but this is a scientific production. The vaccines are scientific productions. Yeah, they've been fast-tracked, but the scientific details were not left out. So
right.
I think by the time we begin to, and this is the time, and time is not on our hands, so if healthcare workers can get the vaccine as the first set of population to get it, before it gets to the general population, we in public health should, raise our voices in support of people taking this vaccine. Like you said,
absolutely.
Like you said, it's not going to hurt; it's going to help.
Exactly.
Right.
And I also myself sought out information and attended a Zoom call that was sponsored by the American Public Health Association on November 18th.
Right.
And in that Zoom panel discussion were Dr. Jim Corey, Dr. James Hildreth of Meharry Medical College, Dr. Jay Barker, and Dr. Marion Grubes, who's the head of the Food and Drug Administration, who talked about the emergency use authorizations and explained very clearly how there have been no shortcuts. There have been fast tracks, but there have absolutely been no shortcuts in terms of each of these pharmaceutical companies needing to follow strict guidelines, strict stopping rules, and very strict safety precautions in place. And I think that, it's also important to keep in mind that vaccines themselves don't save lives. It's vaccinating people
Right,
that's going to save the lives.
right. Thank you. Dr. Tschida, let me ask you a very simple question. The question might sound a little tautological, repeating myself, but I'm going to ask you. So, must the United States uh, government allow their children to die because they have to, by coercion, go back to school? Must it
Mhm.
take teachers taking the street to make the government do a better job of protecting lives of future generations?
I don't currently have school-aged children, but I have had school-aged children. I raised my two boys who are young men now, and I do have uh, step grandchildren who are school-aged, and I think when I see how some of my colleagues and friends and family members who have particularly elementary school age children are struggling to try to homeschool their children, I can have a lot of compassion for why parents are sometimes, in favor of having their children back in the classroom. However, as Dr. Michael Olsterholm of our University of Minnesota Center for Infectious Disease Research and Prevention has said from CIDRAP, we cannot put ourselves in situations where we're swapping air with one another. And that's what happens in classrooms. I'm not an HVAC expert. I don't know heating, ventilation, and air conditioning systems like the back of my hand, who some of my technical brothers and sisters do. But I would know, if I were in a classroom as a student or as a parent of a student or as a faculty member in a classroom of a school, any school, I would want to know from an HVAC expert that these are HEPA filters that are keeping the air in this enclosed room as clean as if I were outside. And unless I can verify that and be ascertained and allayed that fear, because otherwise, if there's not a good enough ventilation system with the circulation of air in so many air exchanges per hour, I may be breathing air that you or another person in the room has exhaled that happens to be transmitting this virus, shedding this virus. And even people who are undetectable with the virus can still be shedding the virus. However, it's like, which is, the U equals U in the HIV virus tracking world. If you're undetectable when you have a HIV/AIDS test, you're generally thought of then as being non-transmittable. A person can still have virus and be shedding the virus and exhaling the virus, even though they're very low and not detectable. It all has to do with dose response. So, if you're exposed enough to enough people who have even low levels of the virus and are not exhibiting any symptoms, you can still become ill and fall ill. The other thing I think about when I hear about the debate that is often getting so emotional at school board meetings about whether school children should be back in the classroom or not, and frustrated parents and frustrated teachers and frustrated school board administrators. There was a time in humanity, in human history, where there was not such a thing as a school, as that institution of schooling children is a relatively recent phenomenon in human history. Who were the children's first teachers before there was a school? We were. The
Parents.
parents were.
Mhm.
So, if I had school-age children, I would be, I'm sure, just as frustrated as many of my friends and relatives are who are trying to homeschool their children right now. But I would want my child home and I would be homeschooling them rather than running the risk of them swapping air with neighbors or others in the school system who may or may not have this virus. And yeah, I fear more for the adults interacting in those school environments than the children themselves, because of how we've seen the illness, present itself by age cohorts. And people who are older or have underlying comorbidities are more at risk. Even in their 30s, which is not old by any means, it's very young from my vantage point, but people in their 30s are dying people in their 40s, in their 50s, and their 60s, and certainly then into the 70s and 80s. And my own cultural value is we should, no one is dispendable. We should be saving the lives of every single human being alive today. I don't care if they're residing in a long-term care facility or assisted living facility. They demand and deserve our respect and our healthcare systems to protect them and prevent them from getting, falling to this virus and dying. And, in Minnesota here now, we have about 5,000 cases of new cases a day, about 70 deaths a day, and 77% of those deaths every day are in the long-term care facility populations. That's not acceptable. It's just not acceptable to me.
It's not acceptable to me either, Dr. Tschida. And another thing that is not acceptable to me is the rise in domestic violence. This has attributed to the lockdown because families have been staying together. Just like every other thing, the US government was unprepared for the fallout of this pandemic. Mm-hmm. Can you tell us what the government has done to minimize the risk of endangering families during this pandemic due to domestic violence?
Yeah, well, again, this is a very sad consequence of being on lockdown and in enclosed spaces with just our immediate families. Tempers are flaring, rates of overdose with opioids and other illicit substances, as well as over-the-counter and prescription medications, are on the rise. It's a very sad situation, and mental health crisis is going along with the physical pandemic crisis with people falling physically ill. And the approach to allaying or trying to address the mental health crisis, again, is just very sporadic and based on what is available in one's own community. Many people, I think, are relying, as they should, very heavily maybe on their faith communities. However, I still don't believe people should be congregating in places of worship. That's my own personal opinion. I attend a spiritual monthly program myself on a Zoom call, and then I have additional weekly calls with faith leaders for my own personal support and my family. But here, at least in the Twin Cities of Minneapolis and St. Paul, I do believe we need more beds available for inpatient hospitalization for people experiencing mental health crises and substance abuse disorders. We have many treatment programs in Minnesota where our license plates say the land of 10,000 lakes, and I've heard others say it's the land also of 10,000 treatment centers. We have Hazelton is here. We have the Betty Ford Center here. We have many treatment facilities for alcoholism and substance abuse recovery programs, but not enough, nowhere near enough. And every state should have more that's available, and more licensed chemical dependency counselors that can triage people and help get them, into the right program. Some people certainly can go in an outpatient basis or start attending 12-step self-help meetings. Others have to be hospitalized because of the drastic and severe withdrawal effects that coming off of a particular substance may have on the person. So, and violence is never, I believe, a solution to any problem in life. Love is. Love is the solution to every problem, and we need more care, we need more compassion, we need more love and understanding. A person who is suffering from a mental health condition or substance abuse disorder is suffering from an ailment just as though they would have been suffering from diabetes or arthritis or any other ailment that has a physical manifestation. It's just that the mental health manifestations have a behavioral component. But individuals that are suffering from those ailments need treatment just like any other health condition. That's my belief.
And that's a great belief, Dr. Tschida. As you were illustrating that fact about domestic violence, my curious mind bubbled a little bit. You know, you mentioned love and you said that violence is not what we need now, we need love. And my mind was like, how come we're beginning to love healthcare workers so much that we want to give them the vaccine first, but when they needed PPEs to work with, when they are so stressed out and maxed out, we weren't there for them. And I wanted to ask you why this sudden love, but I don't expect you to answer it, Dr. Tschida. Rather, I'm gonna ask you a different question, sir.
Okay, yeah.
If nurses and physicians and other allied healthcare professionals cannot be tested for coronavirus, just like those in the White House do, how can ordinary Americans like you and I, who do not have access to healthcare, well, maybe you do, and maybe I do, but other millions of people do not have access to healthcare. How can they, they don't even have insurance. They cannot drive, 1 mile, 2 miles, 4 miles away from their home to the testing centers that have been provided. How can they survive in this pandemic when experts have said that community spread of this virus is a must watch?
Yeah, so I mean, I think like with so many health conditions and diseases throughout history, the focus really should be and should have been all along on prevention. I think that we've had a degradation and a deterioration public health prevention systems, including early testing. So right now, early testing and social distancing and hand washing and wearing of masks are the best strategy. I mean, I saw some educators proposing, the 3 W's for a quick, easy guide to remember what we need to do, even in those instances when children are going back into the classroom, maybe in a hybrid fashion or just like in some rural areas here in Minnesota without any kind of hybrid model. But it's washing of hands. The 3 W's stand for washing of hand, watch your distance, and wearing of mask. Keeping 6 foot minimal. I mean, in some areas, if you think of the 6 foot guideline is really just a guideline. You have to start thinking about the air dynamics of what's going on in our respiratory systems and how other respiratory transmitted diseases are transmitted. If I'm 4'2", it might only have to be 4 feet to stay away from me. But if I'm 8'2", you might have to stay 12 feet, 8 feet away from me. I mean, it really depends on if I'm a carrier of this virus and I cough or sneeze without covering my own mouth or not having a face mask on, how likely are you to then be the recipient of the virus that I'm exhaling into the ambient air, and then you, by chance, unfortunately, inhaling it and becoming infected. And again, it's a dose-response relationship. So when I have to sometimes go into a store to purchase, the basic groceries, or I'm running into a drugstore to pick up medications for myself or my family, I'm in and out. I'm not leisurely sauntering up and down aisles looking for the best sales in the store that day. I'm in to get what I need and I am out, because the likelihood of me being exposed even while wearing a mask will go up the longer I'm lingering in this indoor environment. And then waiting for the testing to be available. If one is without healthcare access and without transportation access to go to maybe a public locale like our convention centers here in the 2 major cities that I'm situated closest to, there is public and free testing going on, but one needs to be able to make it to the Hennepin County Medical Center, the Minneapolis Convention Center, or downtown to the downtown St. Paul Convention Center. There are local public transportation systems. They're limited, but people can get on public transportation and make their way to one of those testing centers. I do believe that more and more testing is going to be available. I do believe, to address the earlier question about why did we not have enough PPE for our beloved healthcare workers earlier in this pandemic, it was such a tragic and unfortunate situation. And people were asked, the general public was asked not to buy up the N95 masks in the local hardware stores and whatnot so that they could be reserved for healthcare providers. That unfortunately gave the message or the signal to people that masks were somehow bad to be worn by the general public. I myself made a mask of a bandana until I was able to find a cloth mask to begin wearing. And, any kind of mask by the general public is better than no mask. So, it's really important, I believe, to put our emphasis on prevention. And then if one is exhibiting any sorts of symptoms or signs of an illness, and or if one has had a potential exposure to someone who you now know may have tested positive, it's extremely important to test and find out as early on as possible if one is positive for COVID or not, because if someone is positive, then they must isolate from others, and anyone in their household must then quarantine. So it's very frustrating that not everyone has equal access to everything that those in the White House were able to have access to. And it was extremely frustrating for me with the 1 week, my college-aged son, who has since moved back home since the pandemic last spring, started showing symptoms. It took me nearly a week to find a place that was able to do a test, because the testing sites were all backed up for almost an entire week. We were going to need to drive to a neighboring state to get him tested. He luckily tested negative, but we did isolate him and we quarantined in my household until we could verify that he was in fact negative. He may have just had a regular flu or something, but the symptoms he was exhibiting of body aches, headache, fatigue, muscle weakness were enough for me to say, we're going to get tested. All of us, but first him, and then the others in the household got tested, and thank goodness we were all negative. But I think it's just extremely important to early test. If you have any symptoms or any known exposures, get tested.
Get tested. I'm glad the result was a very good one for your family, and but unfortunately, many people do not have that access to testing, probably because of, a lot of factors. Even poverty might count as a factor that will keep some people from not, getting tested. And poverty has immense effect on COVID-19 outcomes. Almost 38 million Americans live in poverty as we speak, or more than that even. And homeless families are at higher risk of viral transmission because of crowded living spaces and scarce access to the coronavirus screening and testing facilities. Can you tell us more about this?
Yeah, it's a sad statistic to hear that 38 million American families are experiencing abject poverty, and many people, many people, not only in the U.S. but around the world, are experiencing homelessness. And the the access to a living wage was difficult. Unemployment rates in the U.S. were high even prior to the pandemic, and sadly they've only increased and are likely to continue to increase until we can have the vaccine, have people being willing to obtain the vaccine, having people being able to go back to their workplace and have the economy open up again, and then jobs perhaps coming back and opening up means of livelihood for more people around the nation again. But this is something that I believe as a humanity we have the ability to overcome and survive. The 1918 and 1919 Spanish flu pandemic, some of the human behaviors we're seeing be exhibited now or exhibited then, almost a little over 100 years ago. However, life went on. My father, God rest his soul, Lawrence Tschida, was born on June 10th, 1919.
Oh, wow.
Right in the midst of a pandemic, and he lived to have a career and be married and have 6 children. The youngest of which was me, and so I believe that we'll survive. We will get through this together, but we really need to open our hearts and open our minds and open our arms, in a safe, socially distanced and masked way. We need to help our neighbor and help one another and to help in any way that we can to get through this together. We're one humanity, and we can, I believe, overcome this. I'm looking forward to a new administration coming in January that is going to provide very, I believe, sage and wise leadership. I think that's the type of leader we need right now, along with President-elect Kamala Harris, who I think is a very fair and forward-looking and forward-thinking and astute individual who are going to lead us into a new era. I really believe that a new day is dawning, and we just need to hang in there for this vaccine unrolling and becoming available, and put the focus on prevention. Even after the pandemic, even after the virus has been rolled out, we still need to mask, we will still need to hand wash, we will still need to keep our 6-foot distance and socially distance for some time, because until we can achieve herd immunity globally, there will still be pockets of places where this is community spreading and has the potential to continue to spread and infecting people and making people ill. So it's a sad situation we're in, and I think that I read recently that this pandemic has increased exponentially the wealth of billionaires across the globe by many trillions of dollars, which is sad. This should not be an opportunity for the rich to get richer and the poor to get poorer. There should be an opportunity for us to see us all as one humanity, and we all have the right to access to healthcare, access to food and shelter and clothing and good education and
Yeah, Dr. Tschida, you brought up the fact that your dad was born in 1919, and I'm glad you brought that up. So that will lead me to ask you, can you draw similarities between the 1918-1919 influenza pandemic and the current COVID-19 pandemic?
Yeah, so the pandemic in the early part of the 20th century, the 1900s, was the Spanish flu that impacted very young children more than this current pandemic, which is primarily, causing high rates of death among our elderly. So it looked a little different in that it was a different. It was also a coronavirus, if I'm not mistaken, and I think it was impacting the populations in the U.S. at the time differently for a variety of reasons. I think that 19 teens and 1920s, we didn't, that was about the time of the invention of the automobile and many electric appliances in the kitchen, and refrigerators and freezers weren't available at that time. So I think that the disruption that it caused to lives may have been looking very different. I don't think we had, I know we did not have the medical technologies available at that time to properly care for people when they were admitted to an intensive care unit in a hospital. But we also had a lower overall human population living on the globe, so the likelihood of there being community spread was perhaps less. I've seen photographs from that era. I think one photograph in particular, I think it was a community in Canada where the lady has a mask on. Both of the gentlemen wearing suits and hats have masks on. The woman has a sign around her neck, however, that says, wear a mask or go to jail.
Mm.
I think there were people who were not believing the Spanish flu pandemic was a serious pandemic and didn't think that masks would be effective then either. And so history kind of is repeating itself.
Mm.
I think that we're in a different place in terms of our ability to quickly develop effective, safe vaccines to, maybe curtail how many lives will be lost eventually from this pandemic.
Right.
But likely, there will be other pandemics. This is not the last pandemic that our human species is going to endure, having to learn how to live through. And I'm hoping that we'll learn, not only from what happened in the 1918, 1919 pandemic, but in the future, how to not do certain things and how to do certain things moving forward.
Unfortunately, man refuses to learn from history, and history keeps coming back to attack man. And, and talking about the similarities between the 18 and the 2020 pandemics, who knows what communication methods, was like then, so a lot of things have changed, I guess there wasn't enough, or there wasn't kind of like, there wasn't internet then, so to say.
Right.
There wasn't internet, so the method of receiving, information was like kind of like
slow.
Primitive, in the 1980s and 1990s than what it is right now. So probably that's a huge factor researchers can look into as well. As you know full well, Dr. Tschida, COVID-19 death rates in the US are correlated with patients' age, race, socioeconomic status, and other social determinants of health. Even an MIT research has confirmed this by looking at daily county-level COVID-19 death rates from April to May 2020. So could you please explain this correlation to our audience, if only if you are familiar with that MIT research, or if you have other researches that are related to this, you can buttress your point with us.
I'm sorry, can you repeat the correlation that MIT research found between what and what?
Okay, so the MIT research confirmed that COVID-19 death rates in the US are correlated with patients' age, race,
Yes.
and socioeconomic status. And this research was published between April 4th to May 27, 2020.
Okay. Yeah, so I'm not familiar with this particular research that was done at MIT, but the correlations in the death rates, the mortality rates, have to do with, for the elderly, comorbidities that probably exist among advanced aged individuals, and the correlation between those of lower socioeconomic status sadly relates to their access to healthcare information, I believe, healthcare infrastructures in order to go in for early testing. And that would cut across all disease, classifications. I know some of the research that I was able to do at our state health department here in Minnesota for the cancer surveillance system showed in all sites for cancer across both genders, men and women, African American men and women tended to present later in the stages of their cancer development than any other race in Minnesota. So whether it was lung cancer or prostate cancer or colorectal cancer or breast cancer, it was detected at a late stage, 3 or 4, versus every other race in Minnesota had their cancers diagnosed in stages 1 or 2, or even in a precancerous state. And our local researcher, Dr. Rachel Hardiman here at the University of Minnesota, has found a strong association between people who are able to access better healthcare, who are BIPOC, which is Black, Indigenous, people of color populations, are those that have access to a healthcare provider who mirrors their own race and ethnicity. So a Black pregnant woman is going to have a better birth outcome if her provider is a Black woman or man. And a Native American Indian woman or man is going to have a better health outcome no matter what the condition is if their provider is a Native American Indian man or woman. Same with Asian, same with any, whatever the example is. And to me, I think this bears needing to do additional research into how do we prepare medical students better? How do we recruit more medical students from more diverse backgrounds? And then how do we develop trust? Even if I'm your healthcare provider, Dr. Nduga, how, even though I'm a white man, do I engender trust from you? Even though we're of different race or background. I mean, I believe race is a contrived construct. We're all one race. We're all one human race. But, from a biostatistical standpoint, you and I would be put into different racial categories. Yet I should be able to be your healthcare provider and provide you with absolutely the best kind of care, trust, and understanding as I would if it were a person of my own race. You shouldn't have to mirror my race or I yours for me to render good healthcare to you and develop a trusting relationship. So there's something inherently going on in our medical educational system that is keeping people from being able to form bonds across all socioeconomic strata and lines of difference.
Yes, Dr. Tschida, I would trust my life on you. I know you take good care of it. Yes.
And I you.
Yeah. Thank you, Dr. Tschida. So a New England Journal of Medicine article said that structural racism, social risk factors, and COVID-19, a dangerous convergence for Black Americans.
Mm-hmm.
I will say it again. It's an article, and the title was Structural Racism, Social Risk Factors, and COVID-19, a dangerous convergence for Black Americans. Please kindly take it from there.
Yes. So, social risk factors and social determinants of health and structural racism, is something that I have been interested in finding solutions for probably my entire career, and will continue throughout until the day I die. I see in the U.S. anyway, the reluctance perhaps of dominant white culture to have the necessary dialogue about structural racism, and will often hear my peers of the same racial and ethnic backgrounds as myself say, well, I'm not a racist. And I'm not racist. I can't possibly be racist. There isn't a person who I would ever treat any differently than anyone else. And I think that it's really true that most liberal white Americans don't want to conceive of themselves as possibly being racist or having biases. But I believe if we're living in a racist world and in a racist society, we all have some of that we need to continue to unpack and break down. And I think as um, a noted author and professor has stated, Dr. Ibrahim X. Kendi wrote the book, How to Be an Anti-Racist. It's not enough to just be non-racist. We have to all work at being anti-racist, which means if I'm in any environment ever where there's racist attitudes being expressed, if I'm not willing to stand up and speak out against that racism that I'm hearing, then I am being complicit in that. I'm sorry.
Okay.
And it shouldn't be on the part of the people of color in an organization to lead the charge in how to make an organization or an agency anti-racist. It should be dominant culture people who have the courage to say we have to change our hiring practices, we have to change what we do in our environments in our workplace so that they're not toxic or hostile to people of color and make them friendly for all. How will we do that? It's an ongoing process. It's not that we're going to someday reach the state of being anti-racist in our society and we're done. I believe this is a process. I also believe from having begun reading the book by Isabel Wilkerson, who has written a book called Caste, The Origins of Our Discontents, that we will likely not see the end of racism in our lifetime, sadly. It's going to take several more generations beyond you and I, Dr. Nduka. And, but I believe we can begin the process has begun. I know the Quaker Church in the US and around the world was abolitionists from the beginning, and, they've driven a lot of nonviolent movements, and the process has begun. There are those of us who can keep pushing the process, and those in the next couple of generations that can continue to push the process, but it's a process, and we just have to not give up and believe that eventually humanity will be at a place where we are no longer a structurally racist species. But unfortunately, it's a great injustice. And people talk about reparations here in the US at the end of the Civil War, enslaved Africans were promised 40 acres and a mule and never given that promise. It was never delivered upon. I mean, I think that there are reparations also that need to go on a global standpoint from how many sub-Saharan African, South American, and Asian countries have been colonized and then recolonized and recolonized and recolonized. And I know that there are places in East Africa where tea plantations are no longer functioning from the standpoint of the British plantation owners aren't physically in Kenya and Tanzania anymore. However, the most arable land that could be used for food production is still used for cotton, tobacco, and tea export. And the British don't own that land. They own the plants that are planted on that land. And they're locked in. The people who are living of that land, who depend on that land for their subsistence, are locked in by 100-year contracts that keep getting renewed that prevent them from being able to grow food for subsistence. This is about food sovereignty. I think the same thing perhaps is going on the other side of the African continent in Nigeria with oil refineries and blocking access of fishing villages from being able to have clean, fresh fish to harvest any longer from the sea. That's a food sovereignty issue. And multinational corporations need to be held to task for the damage that's been done and that is continuing to be done. Before reparations can happen, the damage does have to stop eventually.
Dr. Tschida, I wish I didn't ask you this question because the reason I wish that is because the first day you saw me in Minnesota, you trusted me, You believed in me, and you look up to me. And
because you're 6'2".
I like that. Thank you for telling the world my height. Well, thank you for trusting me. Thank you for believing in me. And, you know, I'm your boy anytime, any day. Thank you so much. And you brought the fact that you touched on something that I saw firsthand. I worked for an oil and gas company in Nigeria before I came to the US, and I was privileged to go to a rig site, not as an engineer, but someone who was into logistics. So when we actually flew into this area, I'll mention the name of the area. It's called Uborodo. It's the name of where Chevron has one of its oil location. Uborodo, Ugborodo. I even wrote a poem about it. If you Google it, you'll see the poem I wrote about Uborodo. So when we came out from that helicopter, where this oil and gas company had its facilities were like heaven. That place was like heaven. And once you step out of where the oil and gas company had its facility and you go into the village, I'm talking about just one step out of where they had the oil and gas company has that facility. If you step out of there, all you see will be dirt and rubbish, like swamp all over. And what I saw was unbelievable. 5 feet away from where this oil facility installation was, I saw villagers living inside water. They build their homes inside water, on top of the water. And it was shocking for me. It was so shocking for me. But that is not the topic of today, sir. I don't want you to break down because I know how you feel about issues like this. So I would like us to move to the next point. In Texas, healthcare providers are triaging COVID-19 patients, and they're making decisions about who to send home to gradually expire, to die. These patients do not understand telehealth because they cannot even afford it, probably due to lack of social support or whatever, or inadequate knowledge of they are financially incapacitated. What do you say about this?
It's a sad state of affairs that, when this pandemic was hitting some of our European nations that we think of as being, advanced, Italy and England and Spain and Portugal, and we saw Italian physicians having to triage their patients. And this hit our news media in the US. It was almost as though we looked at that, as we'll never come to that. And here we are in that exact same situation. And it's unfortunate that healthcare providers are having to do that, but they're having to triage and make decisions based on what they believe is at that time, the best they can do. In a time of war, mobile army surgical hospitals have to do some of the same things in wartime. If there's a patient right next to another patient, and one, if you expend the energy and resources and are able to save their life, and you don't know if you'll be able to expend that exact same amount of resource and energy on the other patient and save their life, you go with the one that you believe you're going to be able to save. And this is a time of war. It's as though we are in a time of war, a war against this virus that's killing people. And I'm very sad that those physicians are put in those situations where they have to make those decisions. But it is what it's our reality right now. There are limited numbers of ICU beds. I just saw on our national news last night in Southern California, they've reached less than 15% of the intensive care unit beds, which is why the governor of California has now instituted another lockdown and mandated mask wearing. And, and I think this is going to continue to happen state by state by state unless stricter messages are provided, and then consequences for those who don't follow the guidelines and the recommendations. It's sad. It's very sad.
It's very sad, and I don't want us to end this program on a sad note. Yesterday, I heard that Dr. Fauci has agreed to work under the incoming administration. Good news? Yes.
It's great news.
Yes. And also, another great news is, for full disclosure, Dr. Patrick Tschida was the chair of my dissertation during my PhD program. With that said, Dr. Tschida, I will kindly urge you to say one or two concluding words to my audience.
Sure. Well, I was privileged and honored to be your doctoral dissertation chair, Dr. Nduka, and honestly, you're truly one of my most stellar students in all the accomplishments you've been able to achieve. Of all of the hundreds of students who I've had the privilege of working with, I think of you as truly a Renaissance man. Really, you're involved in so much and doing so much for the public health and for the greater good. And I do look up to you and will always look up to you. And not only because of the difference in our height, but because of what you're accomplishing, and you're shining, and truly, a great leader, and who's going to go on and accomplish more great things, and in any way, in any aspect, as we move forward together, shoulder to shoulder. If I can help you collaborate, let's please do so. Let's work together.
Thank you so much, Dr. Tschida, for coming to Morbidity and Mortality program. Thank you.
Pleasure's mine. Thank you.